Hello, my name is Tiffany Edwards. I'm the manager of value-based clinical integration at West Cancer Center. My role is to integrate value-based care concepts within our organization. I work alongside providers, other nurses, and care support staff from chaplains to social workers to help coordinate and foster better patient outcomes. As many of you know, value-based care is the hot buzzword these days in healthcare. In my role, I recently took on the challenge, along with two other nurse leaders, of using value-based strategies in the field of quality improvement, which is what I wanted to share with you today. We started by identifying a major gap in care coordination at West, but this certainly isn't unique to West, and that is getting patients from the inpatient setting back to the outpatient setting in a timely, well-organized manner. We didn't have a process for this, so we aimed to change that. We wanted to decrease ER utilization, hospitalization, and readmission rates, which would, of course, affect our patient outcomes and quality metrics. We also wanted to take advantage of the reimbursement models like transitional care management that would offer revenue for doing this really well. This model had not fully been developed ever at West. Like any good quality improvement work, you need to know the voice of your customer. So I met with several different parts of our team that I thought this new process would affect, starting with any provider. So a medical doctor, advanced practice provider, met with a pod. So all members supporting the provider, including the nurses and medical assistants, our hospital team, which would include providers and nurses that are seeing our patients in the hospital, care managers, which is my team of nurses. Those are registered nurses who follow patients that are enrolled already in a value-based care model. And then our scheduling team, those who would be responsible for scheduling these patients for their office visits. The baseline data showed a number of inconsistencies. Honestly, it really just illustrated a lack of process or standardization, which of course impacts timely patient care delivery and hospital readmission rates. Things that we observed just from a few days in the clinic, I've listed here. I won't read them all to you, but there was a lot of delay in hearing from the hospital team back to the outpatient setting. And also, no one really knew the goal. Again, we didn't have a process, so we were sort of just like ships passing in the night, everyone wanting to do what's best for the patient, but really not having the tools or the structure to do that. So some lessons we learned is that we need a process, that we can't expect our teams to do something well if they don't have any guidelines or structure. And so we did some things within our policy formation that would mitigate that. Also, I've learned that when you start throwing around any value-based acronyms like TCM, you get a lot of looks. So even just developing better language around what TCM is, transitional care management, and the purpose of it really helped with buy-in. The nerd in me can't help but create a good fishbone diagram, but this really shows all the different factors that can lead to an incomplete or missed hospitalization. Anything from the complexities or sometimes the downside to our electronic medical record, our manpower, our lack of materials, readmission rates, again, not having any formal closing the loop set in place. Again, this just sort of illustrates in a different way the complexity of this. So we developed a SMART goal, and that whole goal was to decrease loss to follow-up and improve continuity of care. We wanted to do this by ensuring that patients that we deem to be moderate to high risk for hospital readmission would see a provider back in the outpatient setting within 2 weeks of hospital discharge. In quality improvement work, it can be really helpful for buy-in, but also for greater understanding to create visuals of your current process. As evidenced by the process map on the left, care transitions were clunky with no team really taking responsibility. It was the wild, wild West Cancer Center. Yes, pun intended. So with the current process, no standardization, it's going to give you exactly what you put into it. A lot of clunky gaps in care. We decided to narrow down how we were going to tackle this big issue to improve the workflow and to manage variation as much as possible. Our whole goal was to simplify and streamline. So we created a policy. The policy started with the hospital team. So basically, if our hospital team decides that a patient is high risk for readmission, and we really have narrowed that down to, are they a cancer patient and are they on treatment? Yes, they're likely, just by many different data sources will show you that those patients are likely to end up right back in the hospital. So if you're a cancer patient of ours on treatment, we see you, we want you to be a TCM patient. So we left it to the hospital team to start that process. Then a scheduler has 2 business days from hospital discharge to call the patient and set up that appointment. And then there's an act of closing the loop via email. This email distribution group also includes care managers who can track these TCM metrics more closely. Also, care managers are calling these patients within the same 2 business day time frame to check on these patients, review their discharge instructions, ensure they received their discharge medications and they're taking them correctly, that home health services have been initiated, and answer any questions that they may have. We also try to help the medical teams by uploading pertinent clinical information from the hospital. That way they have that source to really know what happened while they're in the hospital. This also includes radiology. And then it gets to when the patient comes into the clinic, the providers document on a very specific note that meets all the criteria for billing, and they're able to capture that appropriate TCM charge. So at project launch, we met with all of our voices of the customers, let them know our policy, went over it, educated them, answered any questions they may have. Also, having a physician champion is a big deal. If you have a physician champion, they are able to meet with the providers and discuss on that side of the implementation and really reinforce the project. And so we were very lucky to have Dr. Sylvia Ritchie backing this project for us. With any project, there are early wins and also unforeseeable hurdles, like delay in hospital documentation that we didn't necessarily anticipate. And so we did learn some things in the first 30 days of launching TCM. And ever since then, we have made many changes to our process and really gotten it down to what we think is a more of a fine science. But initially, there were some hesitation. There was a lack of buy-in. We had to work really hard for that initially. So now my TCM baby is almost 2 years old. And within those first several months, there was pushback, and to a degree, there still is. There are missed opportunities and opportunities for more growth. But what matters to me when it comes to value-based clinical integration is creating lasting effects. So this slide will show you that even 2 years in, we are still averaging 84% of our eligible discharge patients being scheduled for a TCM visit. To the data nerds in the room, this is significant. Our numbers are so significant, we actually presented this data at ASCO Quality last September. We were able to show that this process works and it is affecting patient outcomes. Also, this slide will show you that many of those at a high percentage are being billed. And as we know that TCM has significant revenue implications. I wanted to provide another visual just to show you the far left is before we had any TCM policy, and then after we went live in May of 23, having just a policy in place, what this can create. There's some expected variance, but there's overall stability that you'll see in the number of TCM discharges, those that were scheduled and then those that were billed. And we're very proud of this consistency over the last 2 years. In conclusion, I just want to say this is value-based nursing. Again, I know that value-based care is a hot button topic, but from the nursing side, I just want to share that nursing focuses on outcomes, quality, and efficiency. It focuses on how nurses can contribute to measurable improvements while being affordable and patient-centered. Nurses play a central role in care coordination, education, and early intervention. We emphasize preventing avoidable hospitalizations, infections, or any medication issues. In short, the value of value-based nursing is helping healthier patients, lower the cost, and recognition that nurses are the key drivers of any quality care. Thank you for your time.